Can you hear me? Okay, great. Good morning, everybody, and welcome to the 8th Orange County Women's Health Summit. Can you hear? Yeah? Okay, let's try that again. Good morning, everybody, and welcome to the 8th Annual Orange County Women's Health Summit. My name is Allison Sonnenschein, and I am the founding director of the Orange County Women's Health Project. Before we begin, I would just like to take a moment and acknowledge the extraordinary times we are living through right now. It feels like our country is facing a reckoning of sorts. We can't seem to agree and relevant to our summit today, we can't seem to agree on the basics of COVID-19. How great a threat is it? How do we deal with it and overcome COVID-19 as a nation united? And of course, relevant to the events that have transpired over the last week, we are deeply divided over the scourge of systemic racism, the killing of unarmed Black men and boys. How do we even talk about these issues without antagonizing each other? This is a very difficult time, and we at the Women's Health Project stand by our sisters and brothers who are fighting systemic racism, violence, oppression, and hate. We mourn the death of George Floyd and those who have been tragically killed and harmed before him. We grieve for the violence in the streets and the unheard voices that have been silenced. And with these events in mind, we thank you in particular for making time to join us today. Thank you for being here. Let's begin the program now. So today marks the second session in a 4-part series for the Orange County Women's Health Summit. As many of you know, when we originally announced the summit, we had decided to focus on women's health issues through the lifespan. But of course, with the onset of the novel coronavirus, we had no choice but to adapt our theme. And so all 4 parts of this summit will explore various aspects of how COVID-19 is affecting women's health in Orange County and beyond. The first session, which was this past Friday, May 29th, explored at a high level, how is COVID-19 affecting women's health? We also had an update on what's happening at the federal landscape with COVID-19. And we enjoyed a panel discussion about the interplay between COVID-19 and adverse childhood experiences, also known as ACEs. Today's session will explore the relationship between COVID-19 and sexual health, and in particular, how to access sexual and reproductive health services here in Orange County during the pandemic. Our next and third session, which is next Wednesday, June 10th, we'll explore what are the policy implications, in particular regarding women's health, that have surfaced during this pandemic. And the fourth and final session, which is on Wednesday, June 17th, will address COVID-19 and its impact on mental health. Next slide. Today's session will last about 90 minutes. And as you can see on the slide, we have a very exciting panel of experts who will be talking with us today about the county's response. We'll hear from Dr. Helene Calvi to hear how the county's public health department is responding to sexual and reproductive health needs right now during the pandemic. We'll also hear from Beth Schnelly about how Planned Parenthood is adapting its delivery of sexual and reproductive health services, as well as the threats to abortion access throughout the country. And third, we'll hear from Michelle Sherman about some of the challenges that the LGBTQ community have long faced when trying to access sexual reproductive health services in the county, and how that has been exacerbated, of course, during the COVID-19 pandemic. And finally, Joyce Swaving will talk with us about how the pandemic has impacted the delivery of sexual health education and services for our seniors in Orange County. Next slide. I'd like to just begin with a few logistics before we launch into the formal program. So first of all, today's session, as well as all 4 of the sessions, are being recorded and will be uploaded to our summit website, along with all of the presentation slides. So you may not have those slides in front of you, but you will be able to access and download those slides likely later today, tomorrow morning at the latest. And if you look in your chat function, you will see a link to the summit website and the specific page where you will be able to find these materials. That is the video recordings and the presentation slides. Now, we've enabled both the chat and the Q&A features for today's webinar. So we'd like to ask that if you have questions specifically for the speakers about the content of their presentations, please submit those questions through the Q&A feature. But if you have a technical issue and you need some technical support, then please use the chat function to request technical support. We are going to be holding all questions until after all of the panelists have completed their presentations. And then we will have a moderated Q&A session. If we are unable to get to your question, however, we will do our best after this presentation to follow up with the speakers and post those unanswered questions and the answers on our website after today's session. Next slide, please. Now, at the end of today's webinar, you will be automatically directed to an online evaluation survey, and we greatly appreciate your completing that survey because your feedback has definitely informed how we present and what topics we should be addressing in the future. So thank you in advance. We also want to let you know that continuing education units are available today for chess, nursing, LMFT, LCSW, LPCC, and LEP credentials. At the end of the evaluation survey that I just referenced, you will then receive a link to a form where you can request those CEUs. So just to reiterate, you have to complete the online evaluation survey and the CEU request form in order to receive your certificate of completion. Finally, I'd just like to acknowledge and thank the 6 poster presenters that we are featuring on the summit website. They have very graciously adapted their physical posters into virtual poster presentations and recorded narrative explanations. So we hope that you will take the time, and once again in the chat feature, you will see a link to where you can find these virtual posters. And we hope you'll take the time to review those presentations. Next slide. So of course, I have to take a moment, and I'm so honored and thrilled to be able to thank our many generous sponsors, especially this year as we have adapted our normal in-person conference to a virtual 4-part series. Your support has been extremely valuable and allowed us to also present this year's summit at no charge. So thank you first to our lead sponsors at the ambassador level. We have the Arduous Family Foundation. And at the champion level, Carrie and Danny Sunshine, Igal and Sheila Sunshine, and the California Wellness Foundation. Our other sponsors include Guardians, the Shaw family, and Planned Parenthood of Orange and San Bernardino counties. At the advocate level, Pamela Gilmore and the Hoag Women's Health Institute. And at the activist level, Suzanne and Richard Wagner, the Francesca and Giovanna Family Fund, 501c Insight, Cal Optima, and Orange County United Way. Thank you for your generosity. Next slide. None of this would be possible, of course, without the longtime support of our advisory board. That's the advisory board for the Orange County Women's Health Project. It has been such a privilege to work alongside these champions of women's health, many of whom have been part of this organization from the very beginning. And likewise, we have a very strong team. You may not see everybody with me today. You will be hearing throughout this summit series from my colleagues, Dina Rubin, Mona Shaw, and Gail Dratch, but you won't be seeing our program and events coordinator, Sydney Minchin, who has been working so hard behind the scenes to plan and execute this virtual summit series. So thank you, Sydney, for your exemplary work. Next slide. So to get started today, we would like to know two things, and we're going to pop a poll up on your screen, and we ask that you please scroll down, read along with me, and complete this poll in the next 10-15 seconds. So the first thing we'd like to know, and Sydney, please activate the poll, is what do you do? Who's in the room with us, so to speak? If you work outside of the home, then please select whichever title is most appropriate. And if you're retired or you don't work outside of the home, then please select the first option, community member or volunteer. And then our second question is a quick way to get started on our topic today. We'd like to know true or false. You can get COVID-19 from sex. So we'll wait about 5-10 seconds for everybody to complete the poll. Okay, Sydney, I'm going to ask you to close the poll, please, and post the results. So it looks like we have a large number of educators. I'm not sure if that's secondary school or at the post-secondary collegiate level, faculty members, researchers, and health educators, as well as nonprofit and community-based organization staff. We have a fair number of community members, nurses, researchers, social workers, therapists, and counselors, and a good number of students. So thank you. Welcome aboard, everybody. Now let's see. Oh, we're pretty evenly divided. True or false? Can you get COVID-19 from sex? Well, I'm really glad we're doing the session today. Here's what we know. It's kind of a trick question. You can get COVID-19 if you were exposed to somebody who has COVID-19 and you're standing within 6 feet of that person and they cough, sneeze, or breathe out in your space. So if your intimate activity involves being within 6 feet of someone else and they cough, breathe, or sneeze on you, then you can get COVID-19 during that activity. Similarly, we know from the studies so far that direct contact with saliva or mucus can also spread COVID-19. And we're learning that COVID-19 is present in semen, but we don't know yet whether it can be transmitted that way. So that's just a quick teaser. We will be learning more about sexual reproductive health today in the age of COVID-19. But first, we thought it would be important, next slide please, to understand what is the current state of affairs with regard to COVID-19 in the county. Next slide. So this slide shows that as of yesterday, Tuesday, June 2nd, there were 6,574 cumulative cases of COVID-19 to date. So from the time we started counting through yesterday, we're at a little over 6,500 cases in the county, of which 48% were among women and 51% among men. I know that doesn't add up to 100%, but those are our rounding errors. And you can see that depicted on the pie graph to the right. The next data set concerns the death count from COVID-19. And as of yesterday, there were 150 recorded COVID-related deaths in Orange County, of which 41% were women and 58% were men and 1% unknown. So you can see that the death count is affecting men a little more profoundly than the case count. And this is consistent with what's happening around the country. COVID-19 is affecting men more than women throughout the country. I also wanted to just point out, you can see in italics, what the case and death counts were on the day of our first session, which was just this past Friday. So less than a week ago, we were at 5744 in terms of the case count. So in less than a week, we've seen 830 new cases. Fortunately, we've only seen 5 new deaths, but that is still 5 too many. And if you're curious and you'd like to compare the COVID breakdown to the population breakdown in terms of sex, then I've included on the bottom of this slide, which you will be able to access online later, a link to the Orange County population by sex data. Next slide, please. We've been hearing a lot in the news about the racial and ethnic disparities of COVID-19 throughout the country. And it's still a little too soon to tell what's happening in Orange County. Here is a pie graph from yesterday showing the racial and ethnic breakdown. But as you will see, the bright blue section of the pie graph indicates that 30% of COVID cases are unknown race and ethnicity. So although it appears that we do have a pretty significant number of cases affecting the white population and the Hispanic or Latino population in Orange County, an even greater percent of these cases are unknown race and ethnicity. And the data are changing daily. So it's a little unclear how the case count is going to play out among our racial and ethnic groups in the county, other than to say it's pretty widely distributed across all groups. Next slide, please. Now, in contrast, we can see a little bit more profound of the disparity among the death counts in Orange County by race and ethnicity. We actually only have 5% of unknowns. So these numbers are a little more stable. They are, of course, still changing every day. But as you can see, the greatest number of COVID-19 deaths have affected the white community and then the Hispanic or Latino community. There's a surprisingly high number of deaths among the Asian community, which is also significantly higher than the Asian case count on the last slide. So on the last slide, we saw 8% of our COVID cases were affecting the Asian community. But in this slide, we see 18% of deaths affecting the Asian community. But again, all of these data have to be qualified because we still have a reasonable percentage of unknowns. The case counts are changing daily. The death counts are changing daily. And especially when it comes to death counts, there are other variables that affect mortality that vary by race and ethnicity that are not necessarily reflected in these numbers. So please understand this is just a snapshot, but still very important. And I'm very pleased to see that we are tracking the race and ethnic breakdown of both cases and deaths in the county. Next slide, please. So if you're interested in learning more about the state of COVID-19 in Orange County, there are a wealth of websites and resources online. I wanted to just highlight what our healthcare agency, that's our public health department, has made available because it's most pertinent to the content for today. So first of all, we have a dedicated website for COVID-19 in Orange County, and there's also a referral line that is operating during the week from 8 to 5, and links to a number of resources, including the county and state health officers' orders and guidelines, a list of testing sites in the county, state planning guidance, mental health resources, flyers that you can download in multiple languages, and frequently asked questions about COVID-19. And then finally, if you'd like to see those graphs and additional data, not just the case and death counts by sex and race and ethnicity that we've highlighted this morning, but also by age and by city, as well as information on the number of tests that have been performed and the numbers of those hospitalized and in the ICUs here in Orange County due to COVID-19. All of that information can be found and is being updated on a daily basis at the websites that are highlighted here in this slide. Thank you. Next slide. So as I mentioned at the beginning of this program today is the second session in a 4-part series. So I just wanted to highlight that in case you missed it on Friday, to tee up the series, we had a wonderful keynote presentation from Judy Belk, who is the president and CEO of the California Wellness Foundation. And she talked about COVID-19 and women's health in general. She provided a very helpful overview and also acknowledged the foundation's deep commitment to not only the rapid response throughout the state to COVID-19, but also the long-term recovery planning, and that we need to ensure we are focusing on gender, race, place, and immigrant status as we begin the hard work of recovery from COVID-19. Followed by Congressman Harley Ruda, who represents the 48th Congressional District of California, who provided a brief update on what's happening in Congress and at the national level to address COVID-19. He summarized some of the federal legislation that has been passed and that is in the works to assist families and individuals who have been affected by COVID-19, and reiterated his deep commitment to supporting women and families in the recovery. Finally, we enjoyed a very interesting panel discussion about adverse childhood experiences, otherwise known as ACEs, and COVID-19. First, we heard from Dr. Ann Light, the medical director at Orange County's Social Services Agency, who explained the science behind ACEs. How do abuse, neglect, and household dysfunction in childhood actually change the biology of the brain, disrupt neurodevelopment, and increase the risk of long-term health consequences such as depression, cancer, and even lowering of life expectancy. So she kind of laid that out and also introduced some interesting thoughts about how COVID-19, while not itself an adverse childhood experience, can nevertheless exacerbate the response to adverse childhood experiences and what we can expect to see in the short and long term. We next heard from Dr. Eric Ball, who is a pediatrician at Chalk Children's and the immediate past president of the American Academy of Pediatrics in Orange County, who explained ACEs Aware, which is a statewide campaign to raise awareness about ACEs and the impact on health, as well as to train pediatricians and other types of healthcare providers on how to screen and counsel their patients about ACEs and where to refer them. And of course, he talked about how COVID-19, this pandemic, is affecting the rollout of that campaign, but how pediatricians and providers can in fact adapt their screenings to remote and virtual visits so that we can continue to address these health consequences, intervene at an early stage. And although both of our speakers acknowledge that that the COVID-19 pandemic is going to profoundly impact ACEs and the long-term consequences, they also called out some very important strategies that patients can use to build resilience during this pandemic. And if you'd like to learn more about those strategies or anything that I've described in any of these presentations, then I do encourage you to please watch these video recordings and review the presentations that have been posted on the Summit website. Next slide. So the moment we've all been waiting for, we are going to now introduce our panel, and it is my pleasure to introduce our moderator for the panel today, Dr. Devera Hurd. Now, Devera, I know as a longtime member of the Orange County Women's Health Project's advisory board. She retired after 34 years as an administrator and as a teacher in the Santa Ana Unified School District, where she held teaching and principal positions at all levels, elementary and secondary, and holds the unique distinction of being the only principal selected as Principal of the Year for both the elementary and secondary levels in the district. Devera not only volunteers with our organization, but she serves on the board of Komen Orange County, as well as the Center for Collaborative Solutions. And she has been a longtime activist and board member with a number of other local organizations, including the Delta Sigma Theta Sorority Orange County Chapter, the National Coalition of 100 Black Women, and the National Council of Negro Women. I know that Devera's heart and her action has long been in the right place. She has been volunteering since she was 12 years old, and she believes that we need to treat all individuals as valued human beings. Having earned her doctorate in education at the University of Laverne and 2 master's degrees from Pepperdine University, it is my true pleasure to introduce Devera Hurd. Thank you.
Thank you, Allison. I appreciate the opportunity to moderate the panel of these experts on the topic of COVID-19 and sexual health. This panel will feature 4 experts in the field of sexual and reproductive health who will talk about how the OC Health Care Agency, our public health department, has responded to COVID-19 sexual health, how providers have adapted the delivery of sexual and reproductive health services due to COVID-19, unique challenges to the LGBTQ individuals trying to access sexual and reproductive health care, and how COVID-19 has affected the provision of sexual health education for seniors. And now it's my pleasure to introduce those panelists. You see their pictures on the screen. First, Dr. Helene Calvi. She is the Deputy Medical Director of Communicable Disease Control Division, Orange County Healthcare Agency. She's board certified in infectious disease and internal medicine. Helene started her career in academic medicine and moved into public health for the last 20 years with special emphasis on sexually transmitted infections and tuberculosis. From 2012 to 2018, she served as the Deputy County Health Officer for the Orange County Health Care Agency. She cut back to part-time in 2018 in order to volunteer in global health, but in March of this year, she returned full-time to assist with COVID response. Helene has published 10 articles, served on 2 CDC expert panels, and taught STI management to healthcare providers throughout Region 9 and 6 other countries. Countries. Helene earned her MD at UCLA School of Medicine. My son thanks you for that, Helene. Betha Chanelli is the Chief Operating Officer of Planned Parenthood of Orange and San Bernardino counties. Betha has overseen the operation of 9 health centers since 2007. Under her leadership, patient wait times have been reduced to under 15 minutes. The affiliate has consistently maintained Yelp review scores of over 4 stars. Patient volume has grown over 30% in 7 years. Revenues now exceed $90 million. Betha has also helped manage the PPO SBC's expansion into primary care, and she led the implementation of new online health services on the PD Direct app. Betha earned her MPH at UCLA, an MBA at UCI, and a bachelor degree at UCLA. Our third panelist is Michelle Sherman, an advanced practice pharmacist with Radiant Health Centers. Michelle is an internationally recognized HIV specialist pharmacist. After opening the first HIV specialty pharmacy in Southern California, she created the Ubuntu Pharmacist Care Program, which manages drug therapies for people living with HIV. Michelle has also established a nonprofit called the Center for Advanced Pharmacist Care, which promotes pharmacists as critical healthcare providers on a patient's care team. An author and speaker, Michelle is the host of the Conscious Pharmacist podcast. Michelle was raised and educated in South Africa. Our fourth panelist is Joyce Swaving, a certified health educator with Shanti OC. Joyce delivers age-appropriate and medically accurate sexual health education that complies with the California Health Youth Act. She enjoys keeping up with the current lingo so she can engage young people in meaningful dialogue and their developing bodies and help them make healthy decisions around sex, consent, relationships, drug and alcohol use. Joyce also facilitates discussions at senior centers, where she helps seniors explore dating in the golden years and intimacy after the loss of a spouse. Joyce has been a lifelong activist with the HIV community in Laguna Beach. With this illustrious panel now introduced, I invite Dr. Helene Calvi to begin, and the panelists will pass the mic as they're finishing their presentation. Helene?
Good morning, everybody. Can everyone hear me all right? I hope so. I think I need to go back one slide, please. So good morning. Prior to this pandemic, I was happily working part-time in our STD clinic, enjoying doing lectures and had a pretty nice life. And that has totally changed in the last 3 months. I'm exhausted. I'm dealing with many, many outbreaks of COVID. And so I'm happy to take this little break to talk about STDs. The county itself really doesn't do a lot of reproductive health services per se, but we are under regulation and control of doing STD control. Next slide, please. So just to give some national context, I'm sure you're all well aware that STDs have been rising significantly in the last 10 years and really more rapidly in the last 5 years. Gonorrhea and syphilis were both at really historic low levels back in around 2000 to 2010. And now have increased substantially and are at the highest rates in more than 25 years. And very unfortunately, there's been a resurgence of congenital syphilis cases, and we'll delve into each one of these a little bit more. But this infographic from the CDC website shows you that nationwide, chlamydia has increased about 20% since 2014, gonorrhea 63%. Primary and secondary syphilis, about 71%, and congenital syphilis has had a really huge rise. Next slide, please. So the state of the state, and that's the state of California, for STDs it's like every place else. We're kind of always seeing the same increases, but a particularly alarming rise in syphilis that is now starting to affect women and infants. As you can see in this graph, how since 2012, there have been over 100 infants who have been lost to congenital syphilis, and the situation is really not getting better. We'll look at this in a little bit more depth. Next slide, please. So all three diseases on one graph. As you see, chlamydia has had kind of more of a steady increase. It never really was low, and actually you see it rising since 1995, because that's about the time we had a change in diagnosis, had the nucleic acid amplification tests, which are much more sensitive. And as those were rolled out and more testing was done, have been seeing a fairly steady increase in chlamydia the whole time, with the last 5 years maybe being a slightly higher slope. Gonorrhea, we're at fairly low levels in 1999, 2000, had a little increase around 2005, went back down, but now has had more of an increase. And syphilis is hard to see on this slide because of the axes, but we'll have one that points it out better. I'm focusing on early syphilis. That's primary, secondary, and early latent syphilis, because of those are the most recently acquired cases. So the ones that are contagious to others, and they're most likely to have effects on a pregnancy. Next slide. So chlamydia, you see that there's always been kind of this gap between the rates among men and women. If you actually look at studies that have done community-based surveillance where everyone gets tested, those numbers are much closer. So this is somewhat a testing phenomenon where we're finding it in women more because they're coming in for their reproductive health visits and getting tested for chlamydia, whereas men really don't have that same sort of point of contact to be able to be tested for it on a regular basis. Next slide. What's really concerning about chlamydia in women is the reinfection rate. And these slides, by the way, are from the California Department of Public Health, the most up-to-date slides they have. New ones, who know if they'll be coming out this July or not, the way things are going. The reason why we're concerned about repeat chlamydia infections is because in women, if they get repeated infections, these oftentimes can be asymptomatic, lead to chronic inflammation, scarring of the tube. So a woman that has had 2 or 3 chlamydia infections has a much higher risk of getting PID or tubal infertility. And that's why the repeat screen, any woman that is diagnosed with chlamydia should be rescreened for it in about 3 months. So here we see from 3 different data sources, the case reports, managed care, and family planning, that anywhere from 9 to almost 20% of women get it back within 6 months. So that's a very concerning statistic. Next slide, please. So gonorrhea, as I showed before, kind of at low rates, 1999 to 2000, little bump, came back down, but then has been increasing really since about 2010, and increasing more in men than women. So men tend to have about a twofold rate that women have. Next slide. And like chlamydia, repeat infections are not uncommon. It's not quite the same level as chlamydia, so running about 4 to 6%, but again, repeated infections hold a higher risk of adverse reproductive health outcomes. Next slide. So this is syphilis, and we were at a historical low level in 1999, at which point the CDC launched their syphilis elimination campaign, and I like to joke that nothing pisses off a bacteria more than trying to eliminate it, so it immediately started rising again. But that initial rise around 2000 was predominantly in men, and it really isn't until the last 5, 6 years that we've started seeing it in women. I mean, I've been doing STDs all along, and we just didn't see syphilis in women until really the last several years. And both men and women at this point are well above our 2020 objectives. Next slide. So when you look at that rise, kind of break it down by the gender of sex partners, you can see that initially in the first 10 years or so of the syphilis resurgence, it was mostly in men who have sex with men or men who have sex with men and women. And it's really just been in the last 10 years or so that we've started to see it getting into the men who have sex with women population or the heterosexual male population. So when you see that, that's when it starts to hit the women. So women just started really seeing increased rates around 2012. Next slide. So this is the breakdown of the gender of sex partners. So about 55% are in MSMs or MSMWs. About 30% in heterosexual men or men who have sex with women, and 15% in females. And this is a very different graph than what I showed. I do STD lectures on a regular basis. And so this looks very different than the graph that I would show, say, 5, 6 years ago during lectures. Next slide. This is our congenital syphilis rates. And I'm going to say a little bit more about this, but just to point out that California has more than twice the rate of congenital syphilis than the rest of the country. Next slide. So this is a very scary looking slide where you see that congenital syphilis has increased almost tenfold since 2012, and it probably has by now. It doesn't have the 2019 data on there yet. There's a little bit of an explanation for this, though. There was a change in the case definition for congenital syphilis around that time. So that does account for some of this light pink area. Basically, if a woman delivers a baby and she has a positive syphilis test and we cannot verify that she was treated, oftentimes we'll have patients who say, yes, I've been treated. I was treated in this state. I was treated in another country. If we can't verify that treatment, that infant is labeled as a congenital syphilis case. So the good news is that the vast majority of these cases, these 329 in 2018, were ones who had no signs or symptoms, and and now those signs and symptoms can sometimes happen later. So those infants obviously have to be followed over time. But the real concern is the sort of lavender, the dark lavender, and the sort of rose-colored, darker rose-colored at the bottom. Those are the ones who clearly had symptomatic congenital syphilis. So as you can see in the very bottom line of the slide, there were 31 who were born alive with signs of congenital syphilis, and unfortunately 22 infants that were either stillborn or died in the early neonatal period. So these are completely preventable deaths. If these women can access care, prenatal care, have the appropriate testing, the appropriate treatment as early in pregnancy as possible, then this outcome is totally preventable. Next slide. So how has the county responded? First, I'm going to say how the county was responding to just the increase in STDs. And I think some of the following speakers may speak to that, because some of them are the ones that have been helping us in this response. So we have one public STD clinic at the Orange County Healthcare Agency in Santa Ana. There's no way this one clinic can handle all STDs, but testing and treatment of STDs is really pretty standard. Any primary care provider can screen for gonorrhea and chlamydia, can treat gonorrhea and chlamydia. So we really rely on all those primary care providers and reproductive health providers out in the community to do the bulk of that. What's difficult is syphilis. And now since syphilis has been resurging, a lot of providers are not used to dealing with it, don't know how to deal with it, and so don't have the medications, or requires a long-acting form of penicillin that many clinics don't stock. So many, we really see our clinic as being the main source of referral for evaluation and management of syphilis patients. We certainly do see a lot of gonorrhea and chlamydia, no question about it, but that's kind of our bailiwick is a syphilis. So to help us with some of this testing in the community, again, a lot of the gonorrhea and chlamydia increases were seen in men who have sex with men, or MSMWs. So several years ago, we recruited some community partners who had long time been doing HIV testing for us, and got them set up to do more complete STD screening. So they were able to do testing for syphilis, self-collected gonorrhea and chlamydia specimens from extragenital sites. All those specimens were run at the health department free of charge. So that was set up with 3 community partners. We instituted a quick check, walk-in sort of thing, just so that we could see more patients at least one afternoon a week, didn't require an appointment. And we were planning to extend our hours to nighttime and weekends, but then the pandemic hit. Next slide. And so this is what's happened during the pandemic. So you can see the first sort of 2.5 months, or about 2.5 months of the year. The red arrow indicates when the stay-at-home order was put into place. So for those first 2.5 months, we were running about 122 patients seen per week in the clinic. And since that time, it dropped down, quite a lot initially, and even further. So at this point in the last month or so, we have been only seeing around 60 patients per week. So patient visits have dropped by half. Next slide. These are the early syphilis reports. And again, the red arrow indicates where the stay-at-home order was put into place. Now, syphilis takes a little bit longer to, doesn't take long to report, but it takes a while to figure out, to have it staged. So before that report is finalized as a case of early syphilis, it's a several week lag. So you see that for 2 weeks after the stay-at-home order, we still had kind of regular numbers of syphilis being reported, but now that's dropped down again by about half. Next slide. These are the gonorrhea and chlamydia case reports by week. Not the same issue with syphilis. Those are, we get a report, it's a report. And the vast majority of these are reported by outside providers. But you see for the first part of the year before the stay-at-home order, we were averaging, oops, my thing is not showing up here because it's cut off, but it was 265 cases of chlamydia reported per week. And I think it was about 93 gonorrhea. And then since the stay-at-home order, the average have both dropped by more than half. Next slide. So what we did in response to the pandemic, we had still kept open 3 full-time providers providing full STD testing and treatment for symptomatic clients, but we did stop performing screening for pharyngeal gonorrhea and chlamydia because collecting those specimens can lead to a possible exposure event if someone has COVID. We stopped doing asymptomatic screening just to not have as many people in our waiting room. And there's really only a few people showing up per week asking for that service anyway. And switched the routine visits for HIV patients from inpatient to telemedicine. So as you can see, our patient visits have dropped by more than 50%, really. Our community partners did stop doing their STD screening. And as you see, the result is the disease reports have dropped dramatically since the pandemic hit. So does that mean that there's really that much less syphilis, gonorrhea, and chlamydia out there? I don't think so. I think maybe people are having less sex, but I think that there's just likely a large burden of undiagnosed disease, both symptomatic and asymptomatic out there, because people either don't have access to care or are reluctant to come in and get care because of COVID concerns. Next slide. So now we are slowly reintroducing some of the prior services that were deferred. I understand 2 of our 3 community partners will resume STD screening in June, but when will things get back to normal? Who knows? And what will the impact of this undiagnosed burden of disease be? Well, again, I don't think anyone knows for sure, but I think it certainly could have some very significant reproductive health sequelae, particularly around syphilis. So if women are, women are not getting screened for syphilis, especially during their pregnancies, but even if they're just women of reproductive age coming down with syphilis, that's a real concern. And I think once this pandemic is finally over and things get back to normal, I think we'll see even higher levels of disease once the full services start again. Next slide. So just a few thoughts for community providers about how you can safely deliver or do STD screening. Gonorrhea and chlamydia can be easily diagnosed by self-collected specimens. In fact, the vaginal self-collected specimen is the preferred specimen type for screening of women. So if a woman needs to have a chlamydia test checked because she had chlamydia a couple months ago, you don't want to bring her in, you could definitely either mail them the kit, have them come in, pick up the kit, obtain the specimen at home and bring it back, or do it in the restroom in the clinic. Don't really have to do a full exam to do that. Telemedicine and telephone triage, which many places have switched over to. I'm a volunteer with the Lestenac Free Clinic. I had a patient with a rash and the person just took a picture of it and sent it in to me. So that's not ideal, but it's better than nothing. Still, we're having to kind of defer routine preventive services like pap smears for low-risk clients, but certainly for higher-risk clients, someone who had an abnormal pap smear, you don't want to let that go too long. So you want to follow the guidance for symptom screening, social distancing, and masking to reduce potential exposures. I just heard from Dr. Reed, our clinic director, or STD clinic director here at the county, that he had a patient recently with secondary syphilis who was febrile to 101, which can happen in secondary syphilis. We can't send that patient away. So he actually created a private area out in an enclosed patio to be able to examine that patient and do the appropriate evaluation. So in an outdoor setting, probably not available or an option for many providers, but that's just another way to reduce potential exposures when you're not sure if someone has a fever because they have PID or syphilis, or if they have a fever because they have COVID. So I think that's it for me. Back to you, Devera. Hello?
Go ahead, Betha, you're on.
Okay, thank you. Good morning. Can you hear me? All right, good morning. Can you hear me okay?
You sound great. Go ahead.
Okay, great. Thank you. Sorry for the delay there. Hi, my name is Betha Schnelly. I just wanted to start with this first quote here. You can tell the condition of the nation by looking at the status of women. From actually the first Prime Minister of India, written almost 60 years ago, but I think still very relevant today. Next slide, please. I'm Betha Schnelly. I'm the Chief Operating Officer of Planned Parenthood of Orange and San Bernardino counties, and I have a brief presentation here to talk a little bit about women's reproductive and sexual health and how it's being impacted by COVID, as well as the response that we've had to the COVID crisis and also the state of abortion care in the United States. Next slide, please. So I wanted to just start with a couple of definitions. This comes from Reproductive Health Access, I believe, that, women's health really is equivalent to high quality access to quality sexual and reproductive healthcare services. Reproductive health is fundamental and integral to women's overall health. For young women, the annual visit to the OBGYN is often the only consistent contact that they have with the healthcare system. And women 19 to 34 are reportedly more satisfied with their care when their provider when their regular provider is a reproductive healthcare specialist, such as a gynecologist. Next slide, please. Again, just a few slides on definitions. This is the definition of reproductive health care by the Californians for Reproductive Justice. I believe I can't see my bottom of the reference at the bottom, but this was defined. Reproductive health care is defined as quality maternal and infant health, timely birth control access to abortion services, STD prevention, testing, and treatment, and gender affirming care. Next slide, please. So where do women get these reproductive and sexual health care services? Most of us see a primary care provider once a year. There have been efforts to really integrate specialized reproductive health care into primary care visits, but challenges with receiving, really excellent reproductive and sexual health care in the primary care setting include, the primary care physician has insufficient time for detailed preconception, life birth planning, counseling. They're addressing many issues in one 15-minute visit. Also, it's very difficult to keep a generalist primary care population trained on some of the tier 1 more advanced procedures, such as the tier 1 long-acting reversible contraception that includes both IUDs and implants. They're very expensive to keep on your shelves, and they require a lot of training from the provider. So if you're not doing them very often, as a regular PCP office might not, it's very difficult to get good and have them and get good at providing that access. Also, just again, all doctors know this, the specialized nature of medicine, research, new information comes out regularly. It's very difficult to stay on top of everything, at which primary care encompasses everything, and reproductive health care is its own specialized field with constantly new research and information coming out that makes it hard for a PCP to stay on top of that. And we have seen both in studies, and I'll show you some of our own focus groups, that oftentimes women report not feeling extremely comfortable discussing issues of sexual and reproductive health with a primary care provider for fear of being judged or looked down upon for these discussions or their lifestyle. Next slide, please. These are some focus group findings I just wanted to share with you from our own Planned Parenthood group of patients that we do pretty regularly. We do a pulse check, and these are just some of the themes of the comments that we hear often. They prefer to see women's providers for sexual and reproductive health care very often because they feel like the women have gone through it. They have that experience and knowledge. This comment, I feel there is no judgment. It comes up over and over again that patients feel that in their sexual and reproductive health care encounters, it's incredibly important to them to feel they can have an open dialogue with their provider without judgment. And then this last one, again, sort of highlights what I was saying before, which is folks can go to their primary care provider, but often they can't get STD testing and birth control there, which are two of the principles of sexual and reproductive health care that are critical. Next slide, please. So I got through 5 slides in healthcare without mentioning COVID yet, which is, I think, sort of a phenomenon right now. And since March, it seems to be all that we can talk or think about in healthcare. And the impact of COVID on sexual and reproductive health care is enormous and can't be understated, starting with, there is a direct threat to the dollars that are going into both the primary care system right now, as well as the reproductive and sexual health care system. Many of the financial resources of the hospitals and the payers are going towards preparing for and fighting COVID. The state budget is, as you know, has an enormous deficit, and there are threats of cutting funding to primary care and reproductive providers that we are now having to focus on lobbying against. So that's probably one of the biggest threats, is just this diversion of financial resources from the reproductive health care and primary care safety net. Planned Parenthood serves a primarily low-income population, so we give a lot of thought to how will the social determinants of health impact our patient population. And we know that there is going to be increased fear of using public transportation to get to the health centers, lack of childcare that we're experiencing at every level of society that will prevent women from being able to get into their reproductive health care visits. And of course, we all know that most people get their jobs, their insurance through their employer right now. With the unemployment numbers at over 30% now, and a disproportionate impact on women losing their jobs, this means a great loss of insurance, which will mean greater gaps in care for women when they can't get care without worrying about having, the financial impact. We are hearing from our own patients, and we know that primary care practices, especially smaller shops across both counties, we serve Orange and San Bernardino counties, practices are closing and cutting back services. Many of the smaller shops could simply not absorb all of the screening and telemedicine, all of the changes that you had to make within a 1-month timeline to really manage patients during the COVID crisis. And finally, as mentioned earlier by the speaker before me, across the board, the American Medical Association, CDC, ACOG, AAFP all came out and recommended that preventive screenings be delayed because this is this risk management decision, right? I mean, there's a bigger, the risk of having thousands of patients in your health centers versus not getting preventive screening was what every provider was weighing. But specifically in the sexual and reproductive healthcare arena, what this means is since March, most providers, including ourselves, have not been able to do well woman exams. Even at the earlier speaker was discussing, this is just an example in the Planned Parenthood arena, the incredible explosive growth of syphilis in the state of California, which has also disproportionately impacted women of color in the past 5 years. Planned Parenthood was very proud that we were testing everybody with a blood test for syphilis. And that has basically been cut back by almost 60% just because we can't have patients in our health centers for this extended period of time to draw their blood and get this testing done. So it's this difficult decision we're always weighing between contagion of this disease versus the discontinuation of these preventive health services that we know will lead to a public health crisis in the future. Next slide, please. There have been some amazingly positive impacts of the work the healthcare system has done to respond to the coronavirus. So many of the barriers that our patients faced and of the regulatory hurdles that we faced as providers have been eliminated practically overnight. If you had told me before this happened that it was going to happen in healthcare, I would have said, I don't believe it because things don't move that quickly in healthcare, but these are just a few examples. We can now remotely enroll patients in Medi-Cal and presumptive eligibility, which is emergency Medi-Cal for women seeking pregnancy-related services, so pregnant women, and FPAC, which is the family planning emergency branch of Medi-Cal that can be used to cover sexual and reproductive healthcare services. We can do these all remotely now. They used to require an in-person long application, signatures. We are now able to do it either via text or verbally. Video and phone visits are both covered at the same office rate visit as in-person visits. And this has been an enormous boon for providers because we can now provide these visits in a way that patients want to be served without worrying about devastating our practices financially because we can get paid for it. And personally in Planned Parenthood, our show rates for these video visits are 20 to 30% higher than our in-person visits, which I think again speaks to the fact of the disproportionate impact of the social determinants of health on our patients, such as lack of transportation, job shift insecurity that prevents them from making appointments in the clinics, much higher show rates on the video, so better access for patients. We can consent patients online, medical consents, privacy notices. Many utilization limits have been removed from plan coverage. And there was some early information sort of out there about, there's going to be supply chain management problems. There might be a condom shortage, birth control shortage. We have not seen that. Our supply chains have been consistent and healthy throughout this pandemic. Next slide, please. So just a little snapshot to give you, the snapshot of Planned Parenthood, the organization that I'm the chief operating officer of. Is we serve in Orange and San Bernardino counties, we serve over 100,000 patients in a year, and it's over 1 million in the state annually with 108 health centers. We are 95%, patient population is 95% identifies as female, 90% low income. And about 90% of our services are birth control, preventive health, STD related, and primary care. And about 7 to 9%, depending on the affiliate you're speaking of, is abortion services. And we do both medication abortion in all of our health centers and surgical abortion in select locations. Next slide, please. So this is sort of our mantra since March, I think. In Planned Parenthood, everything in the world is a fomite. We see about 2,000 patients in our health centers every month. So just the amount of close contact between patients and providers is enormous in our health centers. So we were required to have a really quick scale back of our services in order to protect our providers, which we really focused on the protection of our providers and our staff first and foremost when this hit. Next slide, please. So this is basically how Planned Parenthood, Orange and San Bernardino counties dealt with how to continue providing care, is that we implemented drive-through visits. So you can see here, we're offering pills, patches, rings, emergency contraception, CT treatment, STI screening, all through drive-through now. So the patient drives to our health center, they log into their phone, they have a video visit with our provider. At the end of the visit, they roll up their window and our medical assistant brings out a brown bag of medication and STD screening supplies to their car and leaves it on the hood of their car. So it's a completely no touch, no contact visit, except for in the case of depot, which we just added. If anyone can figure how to do no touch depot, that'd be great, but we have not figured it out. So these are the services we're offering through drive-through. And our in-health center visits, you can see over here on the far left, we're still seeing anything that would be considered urgent. We have an enormous amount of UTI, urinary tract infection, STD infection visits where people are in immediate pain and need help. We are triaging those patients in the parking lot. We are doing absolutely everything with them we can over video in the car, and then bringing them in to the health center just for that hands-on piece. And then over to the far right, you can see the services excuse me, that we are still not currently able to offer, which does include well woman visits. We do plan to add those back in the next month. And we're looking at perhaps doing a HPV self-screen in the drive-through to determine who needs to be brought through or not. But really our focus has just been on keeping that in-clinic time as low and little as possible to protect both our staff and the patients. Of course, we're doing all of the screening of the symptoms and masking everybody as well. Next slide, please. So just to sort of round this discussion out, what is Planned Parenthood looking at in terms of reproductive, sexual and reproductive health services right now, and what's being attacked, what's our immediate threat. The recent, the Title 10 gag, which I'm sure you're all familiar with, according to the Guttmacher Institute, reduced family planning system capacity to provide contraception services by 46%. It was pretty significant how many providers had to drop out of the Title 10 program due to this gag order that we can't refer or provide abortion services to our patients. Most recently, my affiliate in specific qualified for a small business loan, and in good faith, we applied for the small business loan. Our volume, like many others, was cut to 50%, and we had serious revenue concerns. Just in the last few weeks, we have been disqualified from receiving an SBA small business loan. The claim is that we are a federated model, and we know that we are specifically being targeted by Mitch McConnell and the other Republicans in Congress who wrote this letter to say that we should be disqualified because there are many other federated organizations that are receiving and have received small business loans. But we did end up having to give ours back, so just exacerbating the financial losses that we have suffered in the past 2 months. There are also many state level efforts to define abortion as a non-essential service by the governors in those states, and I'll show you that slide in a minute. Fortunately, that has not been the case in California, where we have an extremely supportive legislature. And then lastly, we always look at what the Supreme Court is looking at, and the two biggest cases that Planned Parenthood is really focusing on related to sexual and reproductive health this year, this summer and spring, is the case requiring physicians to get admitting privileges to hospitals in order to provide abortions in the outpatient, in the ambulatory setting, which we know is unnecessary and also will cause abortion providers to not be able to provide services in those states where they cannot get admitting privileges. and the expanded consciousness exemptions that they're looking at, allowing more employers, not just religiously based, to exempt or opt out of providing birth control coverage to their employees through that employer-sponsored care, which we know is the #1 way that women are covered in the United States for healthcare. Next slide, please. So this is almost my last slide. There's so much misinformation out there about abortion that I always like to put out some actual facts that are researched. I highly recommend going to the Guttmacher Institute if you want additional information. They're an excellent, highly reputed research organization. So 1 in 4 women will have an abortion by the age 45. This is why Planned Parenthood's stance is that abortion is an imperative, integral part of women's sexual reproductive health care, and we refuse to not provide it. 59% of abortions are by patients who have at least 1 child, 75% of abortions below poverty level, and 51% of abortion patients were actually using some kind of method at the time, including condoms or a short-acting hormonal method, which would be a birth control pill that was maybe not taken correctly. There was an amazing study that came out just before COVID hit by this study, National Bureau of Economic Research, which tracked women's credit scores in a 5-year period following the date at which they were denied or unable to receive an abortion. And they found a large and persistent increase in financial distress for women who were denied an abortion by looking at their credit scores. So we know that this impacts women's financial health for years to come. Next, please. And so I was referring earlier to the number of states who have basically said that abortion, try to put governors that have put policies into place to say abortion is a non-essential service. You can see there's about 11 states. As usual, it's clumped around the south of our nation. And unfortunately, these are the same states that many of them, I think all of them I'm looking at, most of them failed to expand Medicaid. There's very little access to birth control and preventive health in those states to begin with. And now the governors are using the COVID crisis to say these patients also should not be able to, we should not be providing abortion. It's not an essential service. And most of those have been stayed in the courts, but it's still being battled out. Last slide, please. I just want to thank you all for having me today, for Allison Sonnenschein for her incredible leadership. I've looked up to Allison for many years for bringing us all together and all of the work and effort that went into this. I have very, very simple takeaway call to action for you. If anything has upset you about what you've heard in my presentation, if your priority is to protect women's sexual and reproductive health, this last slide, I think, says it all. Please register and vote this fall. Thank you.
All right, Michelle, you're good to go.
Great. Hi, everybody. It's a pleasure to be part of the Orange County Women's Health Summit and to be able to present the LGBTQ sexual health care in Orange County to all of you. So it's a pleasure to be on this webinar today. Next slide. I'm going to tell you a little bit about Radiant Health Centers, and many of you are probably very familiar with the organization. It was formerly known as AIDS Service Foundation of Orange County, and they've been providing HIV social services in the community for over 30 years. They've recently, a couple of years ago, changed their name to Radiant Health Centers, and they're the largest provider of LGBTQ health and social services in Orange County. Some of the services that are provided are HIV services, free HIV, STI, and Hep C testing, PrEP and PEP, and rapid ART services, as well as family planning. And I'll go into a bit more detail in the upcoming slides. Next slide. So when Devera introduced me, I'm an HIV pharmacist and an advanced practice pharmacist. So all of you out there are probably thinking, like, what's an advanced practice pharmacist? Everybody's first go-to about a pharmacist is somebody standing out behind the counter at one of these large chains and standing there with your head down, counting in fives and popping pills in bottles. Well, I'm here today to tell you that that's really not what pharmacists are trained to do, and what is an advanced practice pharmacist. So back in 2013, Governor Brown signed a law. It was SB, Senate Bill 493, which recognized pharmacists as healthcare providers. And once this bill was signed, the California State Board of Pharmacy introduced a new pharmacy license designation called an advanced practice pharmacist. So I have my regular RPH license, and attached to that is an additional license, the advanced practice pharmacist license. And out of about 25,000, 30,000 pharmacists in the state of California, there's only right now about 600 advanced practice pharmacists. And we are like clinical pharmacists who can perform functions that are out of that realm that most of you think that a pharmacist does. We are able to perform patient assessments, refer patients to other providers, and operate under a collaborative practice agreement with the clinics and providers that we work with to manage drug therapy, order medications, and actually see patients. So it creates like new opportunities for physicians, hospitals, clinics, health plans to engage pharmacists in managing patients' conditions such as chronic diseases. So in the state, there's a shortage of primary care physicians and other providers. And as pharmacists, we can step in and provide these services to our patients. I mean, when we look at the third leading cause of hospitalizations and mortality for a lot of patients, it's drug-related mortality and morbidity. And there's so many drug interactions and inappropriate drug therapies out there that pharmacists are the key in providing these. And, you know, as an HIV pharmacist, I provide a very essential role with the clinics and the providers like Radiant that I work with. Next slide. So where does LGBTQ sexual health care in Orange County come in to this whole healthcare clinic that Radiant has, and where were we prior to COVID-19? So there are not many safe places for LGBTQ individuals to go to in Orange County, either for HIV care, for PrEP, PEP, family planning and STI testing, or even transgender health. I've had so many encounters with patients where they've been judged. We heard from prior speakers about, you know, women coming to Planned Parenthood who feel safe, like having a woman provider because they don't feel judged. Well, the same goes for people in the LGBTQ community when they go to a provider, whether it's for women's health care. Many women go to providers who don't even ask them about their sexual health or what types of sex are you having. They don't ask those things. For many males, they are not asked those same questions. And I think for transgender individuals, that's even more judgmental. I once had a transgender woman who was HIV positive who was seeing a heterosexual male in the community for HIV care, and the doctor and the office would not call her by the name she wanted to be called because the ID and her insurance card said her male name. So they refused to call her under the name that she wanted to be called. And she asked for a referral to another provider who's going to provide that safe care. So there are a lot of instances in the LGBTQ community where people are not getting the sensitive, non-judgmental care they deserve. And there's also still a lot of stigma attached. So just like we heard about the stigma and the judgment that a lot of women face, well, in the LGBTQ community, that is still alive and well in Orange County. And the services that Radiant provides eliminates a lot of those issues. Next slide. So Radiant centers moved and transitioned from purely like an AIDS service organization, a social service organization, to providing medical care and medical services at the clinic. We have our testing site in Santa Ana, Radar, and it helps fill the void of a lot of these issues that I was talking about earlier. We have the Orange County Healthcare Agency that has the STD clinic that we heard about that provides all these testing services. And this is an additional site where people can get tested. So at Radar, the testers go out into the community. There's a lot of use of social media and a lot of the apps that are used, like Grindr and things like that, advertising these services. So they provide a lot of those testing services. It's a safe environment. It's welcoming and free of stigma. We provide HIV care services. PrEP and PEP are a big focus, as well as family planning and STI testing. So Radiant Health Centers has Title 10 funding to provide like family planning services for women and for men, do the STI testing, as well as transgender health services. Next slide. So this is just a look prior to COVID-19. So this is for the previous fiscal year, just looking at like office visits with the medical provider and kind of what was done. So with medical providers that's either with myself as the advanced practice pharmacist, the physician, or nurse practitioners. There were 484 visits. There were 121 prescriptions written for PrEP. For HIV testing, there were 1,275 clients served. Radar did 639 HIV tests. We did 292 Hep C tests, 25 at Radar. So we used the rapid HIV test and rapid Hep C testing right then and there in the clinic. We do STD testing for gonorrhea, chlamydia, and syphilis using the extragenital swabs. Those tests are then sent off to the county for analysis. For PrEP, the additional services, we've had 619 PrEP referrals. We've had 1,051 PrEP referrals from Radar. PEP, the post-exposure prophylaxis, the non-occupational post-exposure prophylaxis, we've had 34 referrals. We've had the HIV support groups, there are 92 of those, 92 clients that have access to that. So all this was prior to COVID-19. So when March 16th hit and the stay-at-home order went into effect, essentially all the services at Radiant were closed. Next slide. Before we get to that, we'll look at some of the Title 10 funding and the services that were provided in 2019. So you can see we had a total of 102 female users for family planning. So women could come into Radiant and get the whole well woman visit and be offered birth control pills and everything else. I wanted to make a comment about this as an advanced practice pharmacist. As part of pharmacists being recognized as healthcare providers, trained pharmacists can also provide birth control services. I'm trained in this, so if women come and see me, or now via telehealth, I can prescribe birth control pills. I can provide Plan B. I can provide Depo-Provera, the injectable, as well, after a consultation and analysis with the woman as what's going to be the best and most important birth control method for her. Just so all of you out there know, if you want to find resources out in the community where pharmacists can provide this, there's a website called birthcontrolpharmacist.com, and there's actually a map on there. So any woman can log in, go to birthcontrolpharmacist.com and put in her zip code, and it will bring up all the pharmacies in the area that provide these birth control services. So when we have places like Planned Parenthood or Radiant that are at limited service and closed because of COVID-19, women can still access those services by going to birthcontrolpharmacist.com, go to the map, put in your zip code, and it'll bring up all the pharmacies in your area where pharmacists are actually trained. So it's not like you'd walk into any pharmacy and say, I want this. You can find a specific pharmacy that provides these services and then get access to birth control services. So that's also incorporated under this SB 493, where pharmacists are recognized as healthcare providers. Next slide. This is the male family planning, so condoms, STI testing, and things like that. There were a total of 534 males seen. Next slide. These were the unduplicated family planning visits that we saw, like both male and female. The number of unduplicated males were 331, 65 females, and then the number of users, so 2 females and 7 males with positive tests, testing for gonorrhea, chlamydia, and syphilis. So patients that test positive for syphilis are referred to the Orange County Healthcare Agency, where they go for treatment and follow-up. Those with gonorrhea, the same thing. Radiant going forward, once we reopen and expand our services, we'll be treating gonorrhea as well. And we do treat and prescribe treatment for chlamydia for our patients that test positive. Next slide. So what about the LGBTQ community and COVID-19? So just like everybody else who's been speaking, this, we were moving right along, doing everything just fine, seeing patients in the clinic every day, and then bam, we got COVID-19. And everybody had to think on their feet and think creatively, like how are we going to change the way we provide these services so we can still provide them. So how's the LGBTQ community impacted by COVID-19? There's increased exposure and economic disparities and barriers to care that are very well known within the LGBT community, some of which I've mentioned before. So a lot of people don't have access to healthcare. LGBTQ people work in highly affected industries such as the food service, restaurants, food service, healthcare, colleges, universities, and retail. So a lot of people are exposed more to the virus. 1 in 10 LGBTQ individuals are unemployed and are poorer than the rest of the population. And there's a lot of health coverage gaps, some of which I mentioned earlier, but people don't want to access healthcare, don't want to talk about their situation because of stigma, maybe have been ostracized by their community and so forth. So LGBTQ individuals are at very high risk during this pandemic of COVID-19. Next slide. So looking at older individuals, there's a lot of discrimination in housing, employment, and healthcare. All these things that COVID-19 can affect. Increased risk for poverty, increased harassment, increased social isolation. I have so many of my older HIV patients who before COVID-19 were very isolated and very rarely went out into their communities. And now with these stay-at-home orders, people are even more isolated. So how do we reach our community and reach these people to help them, through this issue of COVID-19? Next slide. When we look at youth, so many young kids are rejected by their families. They've been kicked out of their home, that they're homeless. So many of the youth go through extraordinary bullying by their peers and this increased risk of suicide. So COVID-19 layered on top of that exacerbates all these issues that the youth are going through. Next slide. So with everything that I've already gone over, people in the LGBT community are at increased risk for COVID-19. They have increased health risks. The community has more smoking than the non-LGBTQ community, 37% versus 27%. They also have 21% increase asthma versus 14% of the non-LGBTQ community. And as we know, COVID-19 affects the lungs. So just with these increased health risks puts LGBTQ individuals at higher risk. Also, other chronic illnesses and comorbidities, increased risk of HIV in the community, diabetes, cardiovascular disease, and other health chronic health diseases puts the LGBTQ community at higher risk. Next slide. So how did Radiant respond? So Radiant Health Centers was already doing some telehealth in psychiatry, and our focus in our Rapid ART program is a telehealth program. But prior to March 16th, 100% of our services were being provided one-on-one in the clinic. The clinic closed, the whole agency closed on March 16th, and all staff was working from home. So 100% of our clinic services were providing service on Zoom for Rapid ART and then we do the one-on-one testing, the HIV testing and STI testing, developed a protocol for home testing for HIV. Next slide. So this is the medical and provider services that we've provided through April of this year. So in February, we had 56 medical visits, 19 in March and 34 in April. So a total of 109. So once we start, you can see in February, we had 56 visits, and just like the other speakers spoke to, we've really diminished those quite significantly going to telehealth. The telehealth services have been very successful, but the number of visits have been much less than when we were doing the one-on-one clinic services, and people can just walk in to get testing for STIs and things like that. Next slide. Our teleart program, so OC teleart is a rapid start program. So when people get tested for HIV and they test positive, it's a program that's funded by the California Office of AIDS to get people on antiretroviral therapy between 0 and 5 days. Our goal at Radiant is between 0 and 3 days. So if I see a person on for rapid start, I can get them started on treatment either today or within 3 days of their diagnosis. Next slide. The populations that are being targeted are African American MSM, Latinx MSM, transgender women, gay or bisexual men, and transgender men who have sex with men, and as well as people who inject drugs. So this is our target group for this project. That's a 2-year project. Next slide. So where are we so far? So far we've seen 20 rapid ART patients, and 19 were started on antiretrovirals within 5 days. One individual wasn't really a candidate to start therapy right away, but we've started 19 on rapid ART, and the majority of our patients have reached an undetectable level at the next follow-up visit, like 4 to 6 weeks later. So it's been working very well, and doing this via telehealth modality has changed the way we've had to do things somewhat, because when we see the patient face-to-face in the clinic, we can do all the labs right then and there before the patient leaves the clinic. But now through telehealth, where I'm at home, the patient's at home, we've had to send them to Quest to get their labs. And the patients have been extremely compliant with getting their labs done and follow-ups on these visits. And for many patients, this is actually an easier way to attend a clinic visit than having to deal with transportation issues, how they're going to get there and go on. So next slide. We do testing and everything, and we've had to do that remotely now. Next slide. The radar home testing kits, and I know I'm over time, so we'll just go to the last slide. You know, our next steps are to reopen the clinic in early June, have PPE and do all the COVID protocol, and gradually get the clinic back to you know, full service. So I thank you for your time, and thank you so much.
Hi, Joyce, go ahead.
Okay. Good morning. It's a privilege to be with all of you this morning. I want to start out with a disclaimer. The lens in which I am presenting sexual health and services for seniors. I am a 66-year-old woman. I identify as she. I am a mother of 4 and a grandmother of 6, a person of color living in South Orange County. I do not represent all of women's experience throughout the country, and I do not want to claim that I represent that. The opportunity that I have to do sexual health in high schools throughout Orange County that are California Healthy Youth Act compliant, as well as facilitating discussion groups in Orange County, is a great privilege. And it does not qualify me to speak about all women's experiences. The phraseology even around senior health and senior health education. What do we even call our seniors in America? We call them the aged, the old, the elderly. Now, with COVID-19, we are the extremely vulnerable. I also want to claim that we are women of wisdom, capable of hearts. We are adventurous, we're curious, we're friends, we're lovers, we're mobile, we're fully alive and able. Women of a certain age are not sitting around the house in their house dresses, making Jell-O and Jell-O molds. We may be sitting at home in our PJs and sweats due to the pandemic and sheltering at home, but yet we are contributing members of society. I am blessed to be the health educator of Shanti Orange County. We go out and do education in high schools. Shanti is a nonprofit organization that provides mental health services, individual counseling for anxiety, depression, addiction, and anxiety. We also provide HIV care and case management. We refer to wonderful people like Michelle Sherman. We provide support groups as well as community education. All of that is now done through telehealth, and we are very grateful that we have a great retention rate. What I want to share with you today is that senior age women have the same enthusiasm, curiosity, trepidation, and awkwardness about sensuality and sexuality as the freshmen in high school. When I have the opportunity to discuss in the groups at senior centers about sex and sexual health, this is often the first time that women have been able to talk about their desires, their concerns, and ask questions aloud without judgment and stigma. When they are at this point in their life, when they perhaps are looking for a new partner and asking questions about safe sex practices, this is not something that they have had language about, or that they've been even encouraged to have the discussion with their peers, let alone their family members or their healthcare providers. It has been a delight to facilitate these groups because people really are longing to have that candid discussion. We have encouraged people to explore what they are looking for in relationship and to talk about consent, to talk about safer sex practices. We encourage them to go get a sexual health screening. It is often a very uncomfortable and awkward discussion for many of them, and they're squirming around in their chairs, but then you see a light come on and their eyes are wide open and they want more. I was originally scheduled to have a 6-week discussion series in Huntington Beach. And after the 6-week series, they asked for more. And now this has turned into a 6-month program that was cut short due to COVID-19. Many of the women that I spend time with and are in the discussion group have been in long-term relationships, and due to either the death of a spouse or partner, a divorce, a termination of a relationship, or a change in healthcare condition, they find themselves single again. Currently in the US and other developed nations, there is a 60% reporting of the population feeling lonely. Many seniors feel left out, they feel poorly understood, and lack companionship. As we all know, loneliness and being isolated has an impact on our overall health. Many people live with a partner, but still feel alone. In the few months that the situation has changed everything, loneliness has now been exacerbated. People are sheltering in place and being physically distanced by the CDC guidelines to protect the very frail, to protect those who are at the greatest risk of dying from COVID. Enforced social isolation is rare in non-incarcerated population. And during this time of heightened anxiety, financial insecurity, and the outrage at injustice, we are being advised to keep our distance from one another. The senior population is not only being hit harder by the virus, but seniors are now isolated from their loved ones, as their family members are fearful of transmitting the virus to them. Social interactions are almost non-existent. Senior centers are closed. It was once the hub for community and social gatherings, dances, classes, discussion groups, and workout centers. I have deep concern about the impact that this has on our senior population, me included. According to the Journal of Psychiatry, social isolation is damaging to our health and can have the same impact as smoking 15 cigarettes a day. There's been numerous studies that have shown that when people can rely and share their life experience with someone who knows them intimately, it can help their nervous system relax. It helps their brain stay healthy and reduces emotional pain. For the last 2.5 months, I've had the opportunity to be an essential worker in an assisted living community in Anaheim. I am a care manager for an 86-year-old woman who had a bilateral pelvic fracture. Everyone in her senior community is isolated into their own apartment. The staff, of course, has been very caring and considerate and are doing the very best they can. Their dining rooms are closed and all of their meals are delivered in a plastic box on a cart. They eat alone in their apartment. They need to wear masks when they go and get their mail in the hallway. The staff wears masks and gloves. All of the furniture that was out on the patio where they used to congregate has been moved. There is now a central courtyard where people can gather, and the tables and chairs are placed 6 feet apart from one another. Many seniors have the additional challenge of being sight impaired and having trouble hearing. They don't recognize their neighbors. And their beauty parlors are closed, so their hair is longer. And many of the women who have chosen to dye their hair now have inches of gray at their roots and are too embarrassed to be seen in public. I have good news to report as well, that most seniors are extremely resilient. They have survived so much already. They were children of the Depression. They may have lost a spouse and even a child, and many of them their closest friends. For some, their independence. Yet they are still longing for connection. The community that I work at has set up a pen pal program where people can write notes to each other that the staff delivers because they are not to visit each other in their respective apartments. For the seniors who live in their own home and we're starting to explore the possibilities of dating, perhaps on the internet or with those that they have met in the community, they have big decisions to make. If they've met a new partner, now do they need to stay socially isolated? 2 of the discussion group participants started dating, they fell in love, and COVID hit. They needed to decide, would they need to be socially distanced from one another? They had a deep and meaningful conversation, and now they have decided to shelter in place together. One of the women who was just starting to date said that now she feels like she is being treated like a leper. We opened today's Women's Summit with, can COVID-19 be a transmitter in sexual relationships? And people who are within 6 feet of each other, perhaps being physically intimate, they are at greater risk if they are going to share droplets. So the very act of intimacy, one more time, puts people at risk, and especially seniors. So there's a unique challenge for dating for seniors. Many of them have never tried the internet. And we can look now that with all of the senior communities being closed, where are people connecting? Shanti Orange County is doing its best with telecommunication appointments. I have some of my participants who have made personal calls to me because we encourage people to get sexual health screens before they become intimate with partners. And now, because of COVID-19, many of their physicians are not doing in-person visits. So not only is there some discomfort and awkwardness for seniors around talking about their sexual experiences or desires or activities with their medical providers, it's they no longer have access to their physicians. So for some seniors, they are having clandestine meetings with their lovers. They are now not telling their family members that they are now dating again because they don't want to hear and be judged that they are putting themselves at risk. Because one is in their 60s, 70s, or 80s does not mean that they are not longing for sweet connection and sexual romantic intimacy. It is still happening, but it's happening undercover, even in assisted living communities. All of the communities have cameras in the hallways so they can see the movement of their residents. All of that interaction is now discouraged, and there is some reprimand that these seniors are now experiencing. COVID-19 has certainly changed the landscape for seniors. Many of them have been social activists their entire life. They see what is happening on the television. They know what is happening in their communities. Without COVID, they would be out there marching, protesting, having their voices heard. They're afraid, they're anxious, yet they're fully alive and want to be included in the conversation and haven't quite figured out how. Unfortunately, as you can see, I don't have a lot of slides because I'm not very techno savvy, and we've had some health challenges in my own family this week. So I've chosen not to participate in the slide presentation. So seniors who have challenges with technology are now no longer able to connect with family members. They are uncomfortable with telehealth. They've not had that experience before, let alone when it comes to their sexual health. They have that further stigma. When I go into freshman classes and I talk to them about consent, about safe sex practices, about honoring your body, about mutually pleasurable sexual experience, I tell them that these are necessary conversations and we can have them out loud. And then I share with them that I have these very same conversations in senior centers. And I get a lot of groans and eye rolling because young people don't even see seniors as sexual beings. Seniors have a hard time giving themselves permission to be open about their sexual desires and their sexual activity. I'm very grateful that the Women's Health Summit has put senior sexual health as part of its panel discussion. It's an important component, and to have it voiced, to have it said aloud, that yes, seniors are vibrant, they're alive, they have needs, they might have some challenges around technology, but if they are patiently taught, we too can step up. We too can learn new ways. I was very new to this whole Zoom and virtual learning and virtual presentation. And when this opportunity was presented, I was honored to be able to be a part of it. I received a phone call just a few weeks ago from a woman who wants to put herself out there in the internet dating site. She asked, I don't know how to write a profile. She is a cancer survivor. She has had a mastectomy. She asked me, how do I move forward? I don't want to be rejected because of my health condition, but I feel it's only fair to warn any potential partner. Do I tell them that I've had a mastectomy? So we had a very sweet and candid conversation. And I simply made a suggestion that she could say that she was a breast cancer survivor so that she could put that out there. So discussion is still happening on a much smaller scale, but it's still effective, it's still meaningful, it's still necessary, it's still alive. I'm most grateful to be a part of this summit and to be the health educator at Shanty Orange County. Thank you very much for the time that we have been able to spend together today. Thank you. Thank you, Devorah.
Oh, you're more than welcome, Joyce, and thanks to all four of you for your wonderful information, very informative presentations. We've gone over a little bit, but we still want to do a few questions, if we may, please. Betha, I'd like to ask you a question, if I may. You mentioned that you've noticed that people are losing their insurance, as we can well imagine with the jobs. How are you tracking that information, and to whom are you reporting it to help mediate that?
Yeah, so what I mentioned was that we are seeing a higher number of patients who are telling us that their doctor's offices are closed. That is what we're seeing, who are saying they have nowhere else to go because their regular doctor is no longer there. We don't report that to anybody. We don't track it. Unfortunately, all tracking and reporting requires infrastructure and expenses that we just don't have right now. We do also believe that we will see an increase in patients who are losing their insurance, and that has been predicted widely from all of the medical, research associations. That's not just my prediction, but we haven't quite seen that yet. It usually will take a couple of months lag before patients losing their insurance and then enrolling in Medi-Cal or FPAC. Typically, when more people in the community lose their insurance, though, Planned Parenthood volume will go up dramatically because we take all comers, we take uninsured, and we write off all charges. So the main way that we'll know is through our increased enter. But, reporting and tracking, again, is an infrastructure cost that we can't enter unless we, and at some point if it's required of us.
Very good. Thank you, Betha. Helene, we had a question for you. Are the STD screening tests included in the ACA approved health plans?
Yeah, I believe so. I mean, that's part of preventive health, so that should be covered. An annual screening for gonorrhea and chlamydia in women under age 25, and syphilis testing as per recommended by the U.S. Preventive Services Task Force. So yeah, those should be free of charge.
Great.
Right, Betha? Yeah.
That's right. Yeah, I responded to that person as well. Yes, that would be covered in the preventive health services, should be free of charge. Providers often, we find, though, are confused about the fact that you're not allowed to charge a copay or a coinsurance. So often women do find that they'll go and get those services and they do get charges, and it's difficult because it's an issue of consumer education and lobbying for their rights when it comes to the health insurance plans. But yes, you're right. It is covered under the preventive health.
So it would be covered if it's a well woman visit, but if someone has a symptomatic issue,
That's right.
then it's not going to be necessarily covered, right?
That's right. And that's where it's really tricky. Yeah.
Yeah.
That's where it's really tricky with the copays and coinsurance. Yes.
Perfect. Thank you both. Michelle, thank you for expanding on the description and explanation of your credentials. Back in when I was younger, I remember being told to include the pharmacist as a part of my health team. And I took that to heart, and I did start doing that. And now that I am a caregiver for my mother, it's been very important to include the pharmacist to make sure that the medications, et cetera, are commingling appropriately. So thank you for what you do, because it's more important than some people know. Is it often are you often called to help to be on the health team?
Oh, yes, absolutely. So I'm clearly on the team at Radiant as an advanced practice pharmacist, and I also work with the Laguna Beach Community Clinic, but I work with all the HIV providers throughout Orange County and all the other agencies like Joyce mentioned, Shanti, trying to coordinate patients' medications and everything. I mean, I always view like an HIV patient or anybody, a Medicare patient, when they leave the pharmacy with that bag of drugs, it's like a loaded gun. And if you don't know what's in that bag and how to work with it and all the drug interactions and the absolute catastrophic ramifications that can occur, then there's no point. So with this work as an advanced practice pharmacist, I mean, the outcomes for so many of the patients have been quite extraordinary, being able to help them navigate through that, and the results show for themselves. So thank you for saying that. Thank you.
Of course, and thank you. Joyce, our last question obviously is for you. And what we'd like to know is, with the lessons being presented to many of our students over the internet, how our schools, or have you, Betha, this might go to you as well, how has distance learning been covering sexual or health education for our youth that's required? Have you heard of anything that's happening to me?
I have not participated in any tele presentations in high schools, even though it is a required component. Because it hit in March, because we do it in the spring and the fall, so I was able to go to many of the high schools and get that education done before the schools closed for this semester.
Great. So you were able to do it just before.
In person, yes.
Betha, do you have anything to input?
Yeah, Planned Parenthood has a large health education department, and we did actively educate, do sex education in the high schools to help them comply with the California Healthy Youth Act, the CHIA. And ever since March, obviously no educators are allowed in the school, not even teachers are allowed in the school. And we are really in limbo. It's really been difficult. The teachers have barely been able to figure out, and the public schools right now, they're struggling with online teaching in general. And we really don't know. We haven't been told what the plans will be for reintegrating sex education back into the virtual environment. We are able to provide virtual sex education, but we're going to have to wait for the schools to tell us what their plans are, which I think they're struggling right now.
I think you're right. Ladies, thank you so much. And I hope our participants have enjoyed what you've had to share with them as much as all of us that are working on the team. I'm going to turn it back over to Allison and let her close it out. And again, thank you for staying with us a little bit over time. Allison?
Thank you all so much, Devira, Joyce, Helene, Betha, and Michelle. I am so impressed with how quickly all of your organizations have been able to pivot and adapt the delivery of services and education under extraordinary circumstances. It was interesting to see across the board how all of you have been able to track the drop in patient visits due to COVID-19 and how much that lined up with the shelter-in-place order, and how quickly you're also seeing the numbers start to increase again. So that's a real testament to your skills and adaptability. And hopefully it will help mitigate against the longer term health consequences in the sexual and reproductive health arena that we are inevitably going to be facing within the next probably 6 to 12 months. I really want to thank our panelists for sharing the details. It's incredible to think how much we can do outside of the clinic walls. There are real opportunities moving forward, and we're going to be talking about some of these at the policy focused session next week, especially around the use of telehealth and the relaxing of certain rules and regulations on eligibility and alternative delivery methods for healthcare during this pandemic, which perhaps ought to be made permanent and not just a temporary fix. To really hear all of you comment that many of your patients actually prefer the televisits because it avoids the transportation and childcare barriers is very telling and should definitely be lifted in the future discourse about how we rebuild after this crisis emerges or moves from the crisis triage phase to the recovery phase. And we very much look forward to being a part of that planning and conversation with all of you. I want to again thank you, Devira, for skillfully moderating this panel, and to Helene, Betha, Michelle, and Joyce for sharing your very important perspectives on the state of sexual and reproductive health care and access to care during this pandemic. As I mentioned, all of the materials will be uploaded to the website, and we do appreciate very much your completing the evaluation survey when we finish today's program. And remember to request the CEUs at the end of your evaluation survey. Our next session is next week, Wednesday, June 10th, Women's Health Policy and COVID-19. And with that, I will thank you all and look forward to seeing you next week.